Hello, everyone. Hello, everyone, and welcome to our webinar today. It is the human side of HIV using science to combat stigma. We have a very august panel for you today, so we're just going to get right into it. I want to talk a little bit about what our mission is. Our mission, we are a coalition of organizations and individuals dedicated to ending the criminalization of HIV in Ohio. We are mobilizing a broad coalition, including individuals and communities who are disproportionately impacted by HIV, to replace fear-based, stigmatizing laws that criminalize HIV status with evidence-based, non-discriminatory laws that protect public health. Organizations that are part of OHMM include AIDS Task Force of Greater Cleveland, AHF Ohio, Canopy, Caracol, Equality Ohio, Equitas Health, and the University of Toledo College of Medicines. I am your host today. My name is JM. I am the Faith and Justice Organizer at Equality Ohio. And I thank you for coming and joining us today. What to expect today from our webinar? You will learn about the Ohio HIV modernization efforts. You will understand why we need modernization now. Educational insights from community leaders and advocates, really good today. And be asked, begged, and inspired to pledge your support. Make your pledge here at ohmodernizenow.org. I'm in campaign. Our goals today is to hear about urgent needs to modernize Ohio HIV laws, sign the petition. We need your support. The time is now. And share on your social media networks to ask others to sign the pledge. These are our social media hashtags. Feel free to use those throughout the time as you are hashtagging and tweeting responses and things that are coming up for you during this webinar. Finally, I just wanted to show you about how you can join the movement. This is our webinar, ohmodernizenow.org. Please join us by going to the webinar and take a look at all of our things. We have blogs on there. We have stories of people living with HIV and those who are trying to modernize this movement with us. Today, our panelists, I'm going to just introduce really quick who's coming on. Dr. Ann Avery graduated from Case Western Reserve University School of Medicine and completed internal medicine residency at Metro Health Medical Center in Cleveland, Ohio. After a brief time practicing in Arizona, she moved to Miami, Florida, where she completed her infectious disease fellowship training at the University of Miami-Jackson Medical Center in 2003. She returned to Cleveland in 2004 to rejoin Metro Health, where she is the professor of medicine at Case Western Reserve University and the director for the Division of Infectious Diseases. She focused on improving the lives of patients with or at risk for infectious diseases, utilizing a multidisciplinary approach to biomedical, social, and structural interventions. We also have our good friend, Mr. Brian C. Jones. Brian C. Jones has been thriving with AIDS for over 38 years and has been the advocate activist for half that time. He is a national founding member of the International Undetectable Equals Untransmittable campaign, U equals U, a voting member of both the Cleveland Planning Council and the Ryan White Regional Advisory Group. He has presented nationally on mass incarceration, housing instability, HIV, and U equals U. Mr. Jones was instrumental in forming the Ohio Health Modernization Movement, whose mission is to modernize HIV non-disclosure laws in Ohio. Welcome, Mr. Jones. And last but not least, we have Maya Simic. Maya is a licensed social worker and attorney who serves as the legal director for Equality Ohio. Ms. Simic further serves as a clinical law professor and director of Case Western Reserve's Human Trafficking Law Project. I'm going to stop sharing my screen here, and I want to welcome Dr. Avery to the screen. If you want to go ahead and begin, it's so nice for you to be here. Welcome.
All right, thanks for the invitation. Let me get my slides pulled up. Today, we're going to talk a little bit about the science or the lack of science behind the current HIV laws in Ohio. Thank you for the nice introduction, JM. So what's really important to recognize is how the laws lag behind the science. These were created when HIV had no treatable options, and now it is a manageable chronic illness, and the life expectancy for someone who takes their medication and is in medical care is close to the life expectancy of somebody without HIV. Currently, laws in Ohio criminalize both potential exposure, and they're comparable to assault with a deadly weapon and the penalties that are imposed. The law also penalizes potential exposures for behavior that really has no risk of transmitting HIV. We'll talk about that in a moment. And these laws were created back in the late 90s or even late 80s when they were a response to media is anecdotes where data was showing, even though data was showing that most people were taking measures to protect their partners, but there was a lot of fear that generated these laws, and Ohio is not alone in having laws that are really outdated. So what exactly is the law in Ohio? We've got the first one, this felony assault. So if you know you're HIV positive, engage in sexual contact without disclosing your status, it's a second-degree felony. Now, it's important to know that the burden of proof is on the individual living with HIV to prove that they have disclosed, sign a contract or something. So this is a difficult statute. It really puts people, I think, in a challenging situation of a he said, she said, or he said situation. The next one is prosecution of solicitation while living with HIV is a third-degree felony, but it's only a third-degree misdemeanor if you don't have HIV. So there's this upcharge we see. Additionally, you've got loitering to engage in solicitation is a fifth-degree felony, but a third-degree misdemeanor without HIV. So again, an upcharge. The next one, this harassment with a bodily substance, is one that is particularly disturbing because it's gross, but the law is that if you cause another person to come into contact with blood, semen, urine, feces, or other bodily substance, it's a third-degree felony for people with HIV. And this includes spitting and biting and things that don't have a risk of HIV. So while it's gross to have somebody throw urine or stool on you, it's not more dangerous if somebody has HIV versus not. And then the final one is donation of selling blood, plasma, or blood products is a fourth-degree felony for someone living with HIV. Again, this seems very outdated because all of the blood is screened for HIV. And so I'm not quite sure where this one came from. This slide looks at the estimated risk of an exposure, or estimated risk by Exposure Act. And what you can see is that a blood transfusion has the greatest risk per 10,000 exposures. It's, if you're exposed to contaminated blood, there's a very high likelihood that you will acquire HIV. 9,250 out of 10,000 exposures. Compare that to either receptive anal intercourse or sharing needles, where it is more than less than 10-fold or more than 10-fold lower. So receptive anal intercourse, 138 out of 10,000 exposures is still very, very small risk. And half of that for someone that's sharing needles. And then go to the very bottom and you can see this biting, spitting, throwing bodily fluids, including semen or saliva, and sharing sex toys all have a theoretical risk of being able to expose somebody with HIV, but have not been documented. And I did just check to see if there was any new information. You need exposure to blood and you get it through blood and sex. You don't get HIV through other forms of exposure. The other reason that these laws really are outdated relative to science is we know that antiretroviral therapy prevents HIV transmission. There are several studies that demonstrated this. The first one that's listed here is HPTN 052. That was an international study where they looked at 1,800 individuals where one person was HIV positive and one person was HIV negative. We call that serodiscordant. And they followed those couples for over 4,000 patient years. And in that study, they found there were no linked HIV transmission, so no transmission related to the partner who was HIV positive, if the HIV positive individual had an undetectable viral load. So this was a very important study to demonstrate that, and this was looking at early treatment of individuals. So they took individuals who were not eligible for HIV treatment in the country they lived in and started them on treatment just to prevent transmission. So this was an amazing study that really was the first one to clearly demonstrate that being undetectable makes somebody untransmittable. The partner European cohort also looked at couples where there were serodifferent or serodiscordant, but these were individuals that were already undetectable, and the partner had agreed that they didn't want to use any condoms. And so they followed those couples and found the same zero-linked HIV transmissions. So again, some transmissions may have occurred, but they occurred in relationships outside of the couple that was under study. So as of September 2017, CDC endorsed, as does WHO and all the other national agencies, that being undetectable means somebody's untransmittable. And that means that truly means that if somebody is taking their antiretroviral therapy daily as prescribed and both achieve and maintain an undetectable viral load, have no risk of sexually transmitting the infection to an HIV negative partner. And we tell patients this and we share that with them. As I mentioned, somebody that is infected with HIV cannot transmit the infection to another if they're undetectable, but they also can't transmit it by biting, spitting, or throwing bodily fluids. And even still, the riskiest sexual exposure, which is receptive anal intercourse, results in HIV transmission less than 2% of the time when somebody is not using antiretroviral therapy and there are no condoms in place. So it's still a very low risk by a single exposure. There's been no scientific evidence that the laws criminalizing HIV actually have decreased HIV infection or that they have altered sexual behavior, including disclosure. So there are three studies here listed. The first one looks at states with HIV laws, criminal laws, do not have lower rates of HIV or AIDS diagnoses based on surveillance data. So there are 33 states that have criminal laws on the books, and then that means I guess there are 27 states that do not have specific laws. And so when looking at the HIV rates between those two groups, there are not differences. When they looked at persons who were with or at increased risk, they reported no change in sexual behavior, regardless of the presence of the law mandating disclosure or safer sex. And they comment that most people believe it's wrong to expose others to HIV, and disclosure is the right thing to do. And then the final one was looking at a group where patients in New Jersey that had a disclosure law reported the same rates of disclosure, regardless of whether they knew that law existed. So half of the people they surveyed didn't know about the law, but more than 84% in each group had disclosed their status or were abstinent. So no scientific evidence that laws are decreasing new infections or altering behavior. We do know there are negative consequences towards these laws or as a result of these laws that are related to public health. First and foremost is they perpetuate HIV stigma, and stigma is a continuous barrier for engaging patients in HIV care. It is associated with ongoing and persistent depression, as well as poor medication adherence. So anytime we have the opportunity to decrease HIV stigma, which is usually increasing awareness and current medical news, that's a benefit. We have seen that it may discourage people from getting an HIV test. And I've heard this personally, where patients are concerned, they don't want to know if they have HIV because once they know, they could be prosecuted for being sexually active and not having disclosed. So there is a potential of discouraging patients from getting an HIV test, and this was demonstrated by Kessler et al. And then finally, there has been, we think the increased media reporting of criminalization has correlated with fewer people being tested during that following year. So again, scaring people off from getting tested because of the fear of criminalization or being charged. Additionally, criminalization laws exacerbate health disparities. So we know HIV disproportionately burdens communities of color, and communities of color are more likely to be prosecuted under these laws. So in California, for example, 2/3 of people arrested for HIV-specific crimes were Black or Hispanic, while that was only 50% of the population living with HIV in the state. So exacerbating disparities is also something we want to address. So within the CDC, we have launched, we nationally have launched an End the Epidemic plan in the last, I guess really started a year ago. And so in the CDC and the epidemic plan, there is advocacy and encouragement to address these laws that are prohibiting us from moving forward to ending the HIV epidemic. And so CDC quotes, when a law meant to protect the public is not working as intended, is unjust, and may be hurting efforts to keep communities healthy, common solutions must be found to better meet public health and public safety goals. The U.S. Department of Justice released best practices guide to reform HIV-specific criminal laws to align with specific scientifically supported factors, and provides advice to states on modernization. And as of 2014, 5 states had modernized their laws, and those are listed below. So CDC supports modernization. So given what we've heard, it is time to modernize Ohio law. It's overdue. And this slide above reflects the Ohio Health Modernization Movement, and I would support these types of changes to our law. They are certainly better than where we're at now. And I'm going to leave that to others to comment on the recommended changes by OHMM. And so I just want to conclude here that it's really important to understand that people living with HIV have a life expectancy near normal of somebody that near normal or near that of someone without HIV. Our current laws criminalize behaviors with little to no risk of HIV transmission, and such are unjust. They have not been shown to promote less risky behavior or decrease new infections, and in fact, they perpetuate stigma and further health disparities. And finally, they impede our public health goal of getting all HIV-infected persons diagnosed, in care, on meds to stay healthy and end HIV. And thank you for your time.
Right now, we're going to take a pause, and we're going to figure out what we actually retained during that conversation with our poll questions. So drum roll, please. If we can get our poll questions up. The first question is a true or false, and the question is, biting and spitting are common ways HIV is transmitted. Biting and spitting are common ways HIV is transmitted. While we do that, question 2 is, HIV transmission does not need to occur for a person to be convicted of HIV felonious assault in Ohio. HIV transmission does not need to occur for persons to be convicted of HIV felonious assault in Ohio. At this time, I'm going to introduce the wonderful Brian Jones, and he's going to take us into the looks and views as a person living with and thriving with AIDS. Mr. Brian Jones, take it away.
How you doing? Like you said, my name's Brian C. Jones. I'm a person who's been thriving with an AIDS diagnosis for 38 years. I just want to touch on a few things. That language does matter. I am not a person who's HIV positive. I am a person living with HIV. I didn't get infected. I contracted HIV. I don't have a disease. I have a virus. These words are less stigmatizing. I don't use the word disclosure because the word disclosure is also stigmatizing. I prefer to share my status, which is more empowering because it's my status to share. The definition of disclosure is new or secret information. And we have to change the narrative that your HIV status, there's no crime in being HIV positive or a person living with HIV, and it should not be a secret of yours to share. We do know that stigma is one of the main drivers of HIV and AIDS, but internalized stigma is also very prevalent, and for me, it's the greatest stigma. And these laws help perpetuate the stigma in which I have about myself. Usually when people get a diagnosis, they're told that they have a HIV diagnosis, and it's also a felony if they don't disclose. So all you basically hear is AIDS and prison, or AIDS and prisoner, or something like that. So these laws do perpetuate internalized stigma as well as stigma towards people living with HIV. I want to take a different approach in talking about me as a person living with HIV. I know what it feels like to be incarcerated because of my status. I haven't been prosecuted under HIV criminalization laws, but what I mean by that is I was diagnosed my senior year of college, 1983-84, and I started doing advocacy before I knew what it really was. I traveled the world, did musical theater, but I started taking care of friends who had, at this time, this strange gay cancer. So it was an ugly death back then. If anyone knew what the battlefield looked like back then, it was a very, very traumatic death. And I just couldn't see someone taking care of me like that. Even though I was taking care of people, many friends, I lost upward of 60 people in like a year's time. And taking care of those people, I just did not want someone to have to take care of me like that. Even the people I was taking care of didn't know my status. So I decided to go to prison to die. I made a conscious choice to go to prison and die because nothing I seemed to be doing, I didn't have the guts like some people did to commit suicide. I had several friends do that. I just didn't have the strength to do that. So upon going to prison, prior to that, when the ARVs came out, later on, I became resistant to all the medication that was out there, except for the regimen that I was on. And even that regimen wasn't making me any better, but it wasn't making me any worse. So my doctor advised me to stay on that regimen until something came down, that something new was gonna come down the pipes. So upon going into prison, they took me off the regimen. The one regimen that I didn't have resistance to, I wasn't told I had a slight resistance to it. Like I said, it wasn't making me any better, but it wasn't making me any worse. The prison system took me off that regimen and put me on a regimen that I was totally resistant to, just to show that they were giving me HIV medication. And this was very detrimental to me. As a result of them doing that, I had cancer 3 times, with the worst being stage 4 cancer, chained to a prison bed. They wouldn't unchain me to even use the bathroom. I weighed 117 pounds. Stage 4 cancer, the doctor said, Mr. Jones, you're gonna die. I said, you are too. Death has a 100% success rate. But it just goes to show you that incarcerating people does not make the situation any better. Me being a person who was living with HIV, the only way I gained acceptance of my status was when I got housing through a case manager. I had no acceptance or understanding of my HIV status. And even understanding these criminalization laws, I had no understanding what that meant. A lot of times people feel that just because you're living with HIV and someone tells you you have an HIV diagnosis, that you really understand what that means. I'm educated, but I didn't quite understand what it meant. And these laws are vague. So far we have 9 states, 32 states and 2 U.S. territories have HIV-specific laws. 39 states have actually prosecuted under HIV-specific laws or general laws, such as biohazardous waste, attempted murder, weapons of mass destruction. Currently, 9 states have modernized their laws. We have Washington State, California, Nevada, Iowa, Michigan, Texas, Illinois, I might have missed one. North Carolina. Illinois just did a full repeal of their laws. So everyone's looking at that particular state with bated breath. So Dr. Ann Avery mentioned U equals U. Can we get that slide? Is that the slide that's up next? I can't see it anyway. So I'm going to move on. U equals U is undetectable equals untransmittable. I have been a part of the global U equals U movement before it became the global movement in 2016. I'm one of the founding steering committee members of U equals U, and I speak internationally on it. Now, the science behind U equals U, Dr. Anna Avery mentioned 4 studies. She mentioned 3 studies, I think, but there was HPTN 052, which was the first one. The second one was the Partner 1 study. Then there was a study called Opposite Attracts. Now, the Partner 1 study had mixed status couples, which means one's negative and one's positive. There were heterosexual couples. And the one thing about the Partner 1 study is they followed couples with anal sex. A lot of times we tend to think that anal sex is gay sex, but a lot of heterosexual couples were having anal sex. So they followed, I think, 500 couples when it came to anal sex. And it was Opposite Attracts was a study that was done particularly with just gay men. The one study that put the nail in the coffin was the Partner 2 study. And Dr. Allison Rogers, who's one of the lead investigators on that study, said it would take a cumulative 417 years for there to be even a thought of a person living with HIV, transmitting HIV. With these 4 studies, it was over 130,000 condomless sex acts. And I say condomless sex acts because even the CDC changed their language. They used to say unprotected sex, but now they say condomless sex because they do realize that the sex is still protected, even though people are not using condoms. It's still protected against HIV and AIDS. We've known about the science behind U equals U for quite a while. There was a Swiss statement that was issued by Pietro Venazza in 2008, which basically said that a person living with HIV and is on effective treatment, they cannot transmit HIV to their sexual partners. It was very controversial when we heard about it in 2008. The U equals U global movement didn't happen until 2016. But prior to that, doctors were not telling people about U equals U or the fact that they couldn't transmit, because that goes to show you that a lot of the movement prior to that time was very misogynistic and very paternalistic, meaning the AIDS service organizations and other organizations and medical staff felt like they knew what was best for people living with HIV. So, like I said, we've known about the science about U equals U for quite a while. Since the late 90s, actually, there was something called the San Francisco cohort that dealt with pregnant women. And we call that vertical transmission or mother-to-child transmission. They knew that with the medication and a woman being in prenatal care, now mother-to-child transmission is almost non-existent. I think it's less than 5% or 2%. I mean, I'm not a doctor, so. Also, we knew about the Ugandan cohort, which dealt with a viral threshold of 1,500 and below. But for today's science, when we say undetectable, we're talking about a viral load of 200 and below. Those studies, the 4 studies that I mentioned, HPTN 052, the Partner 1 study, Opposite Attracts, and the Partner 2 study, those studies use a viral threshold of 200 and below. So a person can have a viral load as long as it's 200 and below and not be able to transmit HIV to their sexual partners. Now, I'm going to talk about something called the Stigma Index. The Stigma Index is the largest social somebody's at my door, Brett. The Stigma Index is the largest social media project of its kind. It was implemented, developed by people living with HIV. It has been implemented in over 100 countries, and over 1,000 people have been interviewed. It first started in 2008, but it came to the United States in 2013, and several states implemented the Stigma Index. The one I'm going to talk about particularly is Michigan, which in 2013 did the Stigma Index. And I mention the Stigma Index because it's very important. We learn a lot of valuable information from the Stigma Index. The Stigma Index tells us that 49% of the people who were interviewed felt that it wasn't necessarily reasonable to delay care for fear of prosecution, but an overwhelming 51% thought that it was reasonable and very likely for them to delay prosecution because of the fact that they, to delay medical care, to delay medical care of fear of being prosecuted. 51% felt it was reasonable and very likely to delay care for fear of being prosecuted. We also learned that many people through the Stigma Index received a diagnosis 1 year, and the following year they got retested again because they didn't believe it. That goes to show that just because people tell you have an HIV diagnosis, that doesn't mean you understand it or have acceptance of that, because quite a few people who were a part of the Stigma Index admitted to getting retested the following year. Also, many people felt that they did not want to be in care because they were afraid that their doctors would be called upon to speak against them in a prosecution case. An overwhelming 68% of those people in the Stigma Index felt that they would not be given a fair trial. So we look at the Stigma Index and we look at Black folks and people of color and mass incarceration being real. HIV criminalization laws is just another notch in prosecuting and sacrificing Black lives and Black bodies. And me as a person living with HIV, it's hard. I'm as open about my status as anybody could be, but I still live in fear and sleep in fear, waiting for a knock at my door of someone saying that I did not share my status. I have been blackmailed by people whom I said, of one particular individual, I said, well, they explained to me after I shared my status that they thought they had come in contact with HIV. And I said, well, let me know if you need help. I'll go with you to get tested. They called me a few months later and said they need my help. I said, good. They say, I need somewhere to stay. I said, that was not the kind of help I was talking about. I said, remember, you told me you thought you had been exposed to HIV, and I said I would go with you to get tested. They said, no, I don't remember that. I remember us sleeping together, and you gave me HIV, and I'm going to the police if you don't let me stay with you. I said, well, you go right ahead, because we had to at least hold hands, and we didn't even do that. So it goes to show you that how these laws have done everything contrary to helping people, to help the public. We've learned about these laws in the later part of 1988 when these laws came about. But these laws actually were instituted across the country when the Ryan White Care Act was implemented. The government wanted states to have some accountability, so these laws were formed. But when the Ryan White Care Act was reauthorized, that was not a part of it. So the government knew that these laws didn't need to be in place, but they left it up to the states. And the states have held on to these laws and have held on to the stigma, and the lack of these archaic laws don't match the science. What it does everything contrary to that. It keeps people in abusive relationships. It also has the potential to take women away from their children. Also, the law says that a person who you disclose to has got to understand mentally what disclosure means. But the law doesn't protect the person who's supposed to do the disclosing. And because it says the person that I disclose to needs to understand mentally what disclosure means. But what if me as a person living with HIV and I have a mental condition, it doesn't protect me. So these laws have done everything contrary to that. I know I have given y'all a lot of information, but that's how it is. HIV and AIDS can be very complex, and we ask that you join us in modernizing these laws. I think I've covered everything, JM. Thank you.
Mr. Jones, always a pleasure to hear from you. So we are going to, at this time, bring up another poll question. We only need to do question 3. Question 3 is U equals U means. Is it undetectable equals uninfectious, undetectable equals untransmittable, or undetectable equals arrestable? And at this time, I'm going to go ahead and turn it over to Maya. Maya, go ahead and take it away. Thank you so much for being here.
All right, all. So what we want to do is we want to go and build off of some of the information we've already heard. We know that we have a mixed audience today of lawyers and non-lawyers, but I do, for the sake of some of the lawyers in the room, and for the sake of like having people understand when we talk about these laws being a little bit discordant, we want to have a more clear picture of what that looks like. And so we're going to break down some of the ways in which the laws have been disproportionately impacting people living with HIV and AIDS. And so Dr. Avery set us up very nicely to talk about this. And so there are 6 different laws that are in Ohio that are actually used to penalize people who are living with HIV and AIDS. And we're going to go into what that actually looks like. So having a little bit of the background of an understanding of how the science does not align to an increased punishment or penalty for these actions. We want to like process through and see why that is so important for us to realize and work against. So misdemeanors and felonies, right? So misdemeanors are lower level offenses. They tend to range, you can see here, from about $150 of a penalty to up to $1,000, and no jail time to up to 180 days. So that is all under a year. And then when you go to felonies, you can see that the felonies tend to be, the felonies tend to be higher, right? And so the felonies are ranging from fines of $2,500 up to $20,000. And we have about six months potential of jail time up to 11 years, right? So looking here, you can see that there's a big difference in some of the ways in which the sentencing occurs for folks. And why that matters for us is when we look at these 6 different tiered offenses that we're talking about that are disproportionately targeting people living with HIV and AIDS, we are seeing that the sentencing disparities are significantly impacting people's lived experiences for ways in which they actually cannot intend or provide any additional harm than what was contemplated by the initial statute. So starting off with solicitation, right? So that is asking someone to trade something for a sexual act, right? And so you have a conversation, you say, hi, I would like to have a sexual act with you. In exchange, I would like this money, this item, this place to stay, this kind of drug, whatever the interaction is, it is literally having this conversation, right? So solicitation. It's important to know, so like nothing has happened. This is literally the conversation that's occurred. And when we look at what it actually goes on, the difference between the 2 penalties, as you can see in the chart. So the top line is penalties for people living with HIV and AIDS, and the bottom is it indicates penalties for living with people who do not have HIV and AIDS. And so you can see that for a conviction of solicitation, for someone who is not living with HIV and AIDS, you might be able to be charged and receive 60 days of incarceration, as well as a fee of $500. Whereas if you are living with HIV and AIDS, it jumps substantially to 1 to 5 years potential for going to prison, as well as $10,000 and a 3rd degree felony. So you can see that this is the kind of disparate treatment that individuals are subjected to because of the fact they have an HIV positive diagnosis, even though the intent or the action has not caused any additional harm to anyone, because it couldn't, because it's a conversation, right? So this is the first step of trying to understand why we need to advocate for a modernization of these laws. It's extremely unjust. The next one, so, and again, this is a grouping of the laws. 4 of the 6 of the laws have this heightened penalty that we see. So we can see here is the next one is loitering to engage in solicitation. Now, loitering is when you are looking at like the description, it is asking someone, like standing around and waving your hands and gesturing at people and trying to get them to kind of come to you, right? And where we have seen this really impact people that we have noted is in particular areas where people are hanging out on corners and people are hanging out on sidewalks. So if you are in a neighborhood where people tend to congregate outside of buildings because that is a cultural norm, if you're hanging in a place where people are gesturing while standing on, and this can either be called the devil strip or the area of land that tends to be right next to a road, called different things in different places across Ohio, and you gesture at someone who's across the street, how a police officer interprets whether or not you are actually falling into loitering has been extremely problematic and very targeting of Black and brown individuals inherently. And so if you are loitering, again, have not done anything to put anyone in jeopardy, but what you are accused of doing is loitering, the penalties again are going to be increased based on what is going on with these codes that target individuals living with HIV and AIDS. And so you can see here that if you are living with HIV and AIDS, you can have up to 12 months jail and $2,500, and it's a 5th-degree felony. Whereas if you are not living with HIV and AIDS, you have a 60-day possible chance of incarceration and a $500 fee for a 3rd-degree misdemeanor. So again, when we're seeing not even any kind of transmission, not any exchange, not anything at all, as well as a very broad range of interpretation of what it can look like to be moving through the world and talking. I talk with my hands a lot. I know a lot of people who gesture in very large ways, right? And so how we leave that for the interpretation of different professionals to or police officers to try to say like that is what they are doing, and now I'm going to subject them to a felony because of it, is extremely problematic for people. The next one is deemed prostitution. So the law indicates that prostitution is sexual activity for hire. And this has been interpreted in a multitude of ways that are also important to note. So if we're talking about sex, some examples of prostitution can be oral sex. It can be the exchange of like digital manipulation of someone's genitalia. So sexual activity has, again, a wide interpretation. And thinking back to what Dr. Avery said, a lot of those are not ways in which we actually can see the transmission or a potential of transmitting HIV. And even so, when looking at the penalties that we're seeing here, you can see that a penalty for someone living with HIV and AIDS would be a conviction potentially of 1 to 5 years of possible incarceration, as well as $10,000 with a 3rd-degree felony. And a penalty if someone wasn't living with HIV and AIDS would be 60 days and $500 and a 3rd-degree misdemeanor. So we jumped from a misdemeanor offense to a felonious offense for something that may or may not have even had an element of transmitting any of the bodily substances that may transmit HIV or AIDS, and again, not reliant on science. And so again, when we're considering how the disparate impact is on individuals living with HIV and AIDS and what that is doing to different communities, you start to see like the substantial difference between the penalties that we are talking about here. All right, so number 4 is harassment with a bodily substance. And harassment with a bodily substance was formerly called harassment by an inmate, but that's an old term. It does not have to do anything with having to be incarcerated. And so essentially what you're looking at is one person is causing another person to come into contact with blood, semen, or any other bodily substance. So we see this, we have seen this often with cases where people are spitting. And again, if we're thinking back to the science that we have talked about with Dr. Avery, these are not ways in which people are going to have a high likelihood, if at all, of transmission. And so when we're looking at harassment with a bodily substance, the thing that's important to note is we are doing this really nifty study in Equality Ohio, trying to prove just how harmful these laws are. And we have an amazing, brilliant colleague, Delaney Barr, who's been working at collecting all of the information about incarceration across the state. And hopefully we'll have that to you within the first quarter of 2022. This harassment with a bodily substance has been something that we have seen have a substantially higher likelihood of all of the offenses of being charged. And it's very interesting, and we're not entirely sure why that is, but it's something that we've definitely noted as we've been going through. And so another item that we're just looking at, so when we're talking about penalties, we can see that it's 6 to 12 months and $2,500 versus 1 to 5 years and $10,000, felony 3 to a felony 5 for people with an HIV status or not. So as we're rounding the corner of the last two articles that we wanted to talk about, so we have felonious assault and we have selling or donating contaminated blood. These are two that criminalize. There are laws specifically under the revised code that criminalize people because of their HIV status. So felonious assault, and it prohibits you from doing these 3 items, right? And so engaging in sexual conduct with someone without disclosing your HIV status. And we heard Brian say disclosing feels stigmatizing and it isn't something that a lot of people resonate with. And so for the purposes of just naming that, so sharing your status with someone else is a requirement of the law before engaging in sexual contact. If you engage in sexual, conduct with someone and you know or have reason to think that they can't understand the significance of your status, or if you engage in sexual contact with someone and they are younger than 18 years old. So as Brian had made mention, these are extremely problematic because the implementation and enforcement of these different requirements is hard, it's haphazard. And if you think about the first one, before having sexual conduct, you have to ensure whether or not a person knows about your status and capture that. Think of the burden that is on someone living with HIV and AIDS. How do you capture it appropriately? What does it look like? How are you going to document it? How also, looking at the second bullet point, are we making sure that person understands the significance and understands fully what is happening there? How is it that we're putting upon people the ability to understand people's mental health, mental states, whether or not they're impaired by a substance that they may or may not have consumed in your presence? All of these are factors that are not fair to burden on someone to make sure that they are able to engage in what is a normal human interaction, which is sexual contact, right? And so there's a lot happening here that causes a lot of he said versus she said kind of information, because also there's not always going to be someone around that's going to be able to verify that you have disclosed to that partner. So when you're having a sexual encounter, how are you going to ensure that if things go bad in a breakup, and side note, they tend to go bad in breakups, right? That someone isn't going to use this against you, even if they knew that you had disclosed to them in advance, right? So there's a lot happening here, and there's a lot of very dangerous and then stigmatizing ways in which we are penalizing people and trying to seemingly prevent intimacy, because this is very broad. When you look further at what it says for the felonious assault, you see that sexual conduct has a lot of definitions, and it ranges from vaginal intercourse to anal sex to oral sex, regardless of the sexual the sex or gender of the individuals engaging in the action. But also it talks about the insertion of an object into an opening, a bodily opening of someone, which includes things such as sharing of sex toys. And the sharing of sex toys, whether or not it's been washed before, whether or not it has a condom on it, any of those items are not what the law is prescribing to say that they're looking at the risk. They're not looking at risk. They're just looking at the act and whether or not the act was done. And so if someone does engage in any of those actions and has sex and cannot verify that they had shared their status with someone else, we are looking at a 2nd-degree felony in Ohio, which has 2 to 8 years per occurrence. So it's per sexual event that happens. So it's not just every time you've had sex, because it's just like lumped into one, it is stackable. So if you've had sex with someone a variety of times, those are all potentially different charges that can stack. And it also has a requirement of a potential sexual offense registration, which impacts how that person thereafter would be able to move through life, get housing, get employment, all kinds of different items that would substantially detrimentally impact that person's way of living and moving through the world. The last one is the selling or donating of contaminated blood, and it prevents you, if you have HIV, from selling or donating your blood or plasma or any other product. And what is fascinating here is just by the selling of the blood, not even considering that it has to be screened and tested before it's used, that it's not going to be just given to someone, right? Because science and protocol. But if you are found to have donated or sold your blood, that you could be still charged with a 4th-degree felony, which has 6 to 18 months of a potential jail time. So again, as a practitioner, as someone who is trying to talk about why this is important, when we see laws and we understand how detrimentally impactful they are on different communities, I think it becomes a part of our duty, whether we are in a social service provider or we are a legal provider, to then take that information and knowledge and advocate for change, because laws, particularly laws that are not based in science, that are detrimentally impacting communities disproportionately so, they are not laws that we should be allowing to stay on the book, particularly when we know that they're causing so much harm. So the amount of stigma that we see for people living with HIV and AIDS, and the fact that it doesn't take into account the actual scientific risk, or whether or not there was an intention to transmit or to cause a transmission of the virus from one person to another, or if there even was an actual harm that occurred, impacts many facets of individuals' lives. And we want to just keep elevating why, as Ohioans, that's not the kind of state that we want to live in, is being okay and accepting of laws that continue to perpetuate harm without any justification. It's also costly. So it's costly, and the reason why it's costly is because it's taking away from areas in which keeping people incarcerated might be able to be better spent using on prevention efforts, on clean needle exchanges, on ways in which we can actually further the conversation around what it would take to keep people sexually healthy and sexually protected, as opposed to criminalizing or penalizing. And what's more, there are other dockets and examples in different states across the United States that have diversionary programs, where there are ways in which we can attend to the whole self of a person who's living with HIV and AIDS, and not automatically presume that one misstep should lead to a felony in this manner, when it's a law that doesn't have any justification or backing, right? So are there ways in which we can think about how we might be able to make the justice system on these issues a little bit more inherently attendant to the person that is coming into this interaction, as opposed to just throwing people into a cell? I think merits consideration, and the answer is absolutely. And we've seen it done with a variety of populations, even in Ohio, with layers of success that I think would serve us better. So just some wrap-up points as we're talking about why these laws are based on just even the sentencing we've seen. But do our current laws require a state of mind intention? No. Do they take into account risk reduction? Is the person wearing condoms? Is the person taking meds? No. Does it remove any HIV specific felonies? No, it's not proportionate to the harm that has been done. And does it require proof of transmission? No. So some of the proposals of the law, again, so micro lived experience of people trying to translate into those macro level changes that will impact our entire community and try to reduce the stigma that's being experienced. We can see there are tons of ways in which we can start advocating for better laws around this. The last slide I would say, so some of the other areas of the law that we find to be problematic, does this remove any penalties for other health conditions? No. Does it remove the registration for sex offender? So no, like, right. So what to what end are we requiring these implementations happening? And does it remove donation procedures? And the answer is no. So these laws should take into account the actual lived problems that can occur. And for example, why are we even considering it, still having the conversation around blood donation as a problem when we know that that's just not, there's not a likelihood of that causing any detrimental impact on people. So these are some of the considerations we wanted to leave you with. We're so glad you're here. I really thank you for your time, and I'm going to turn it back over to JM to have our final poll.
Excellent. Thank you so much, Maya. I do appreciate that. If I can have everyone, all of our panelists to come back, we're going to take the last couple of moments to have, the last 10% or answer any questions that may have come up.
Well, I did answer a question that, are there any symptoms? Quite often there may not be symptoms, but there could be flu-like symptoms that may, or depending on when, you might experience an opportunistic infection. I do know that a lot of times by people getting tested late, we're seeing people coming into the emergency room and they're receiving an AIDS diagnosis because of late testing. I often say that Black people believe in health sick, not health care. We only think about our health when we're sick, and we use the emergency room as our primary care doctor. So because of these laws, people are not getting tested. We do know that. And a lot of times, like I said, a lot of times we're seeing people get tested and they're getting tested late. So something that could have been avoided, they're coming into the emergency room with an AIDS diagnosis as opposed to just being a person who is being diagnosed with HIV. So we need to get more people tested earlier. And by doing that, removing these laws would help facilitate that. Dr. Avery, you can check me if I said something wrong.
Oh, you were right on, Brian. In addition, I put in the chat that it is challenging. I mean, we don't recommend testing solely by symptoms. We want to make sure that we are getting everybody tested at least once in their lifetime, and more often if there are risk behaviors that would indicate a higher risk of exposure. So getting tested is not dependent on symptoms. The other thing I would add on that I hadn't thought about until Maya was talking with the blood donation is that, we now, as of 2013, have the HOPE Act, which allows HIV positive individuals to donate organs so they can be organ donors. And that allows for an HIV positive individual can receive an organ transplant, and now HIV positive donors can donate organs to individuals. And we're not talking about transplanting an HIV positive organ into an HIV negative individual, but it's organ transplantation seems a lot riskier than a blood donation. So